sponsored by Janssen Oncology. And our speaker is Dr. Prakash Singh Shekhawat, clinical hematologist from Jaipur. And he'll be talking on the topic approach to treatment of myeloma and achieving rapid, deep, and durable response with Daratumumab in frontline and first relapse. So I welcome Prakash sir to the stage.
Good morning to all of you, and we are back after tea. Good stimulant. So I think everyone is alert now, and especially after a wonderful lecture by Hemant sir. So I will be speaking on myeloma, and because some of students are there and few physicians who are very up to date and interested, so I have decided to keep my talk this one as a bit basic, so it can help the society much. So regarding myeloma, we know that it's one of the very commonest blood cancer and usually affects the elderly population, and most commonly it affects male predominant slightly more than a female, and age group is around 55 to 65. In India, as Hemant sir said, some of the diseases present early because of a huge young population. So myeloma itself is not a disease particularly, it's not one disease. It is a kind of syndrome because it has varied manifestations, and it can affect different systems. Like it commonly affects kidney, it affects the marrow, it's obvious, then it affects the bones and nerves. So we can have different symptomatology of multiple myeloma, and there is a mutational burden as the course goes on. And myeloma is a disease where we have come a huge distance. We have improved the care of multiple myeloma from a very lethal disease, and nowadays we are talking about cure in myeloma also. So how to diagnose a myeloma means what are the diagnostic criteria that when we say this is a case of myeloma. So initially it was CRAB criteria, like the hypercalcemia, renal involvement, then anemia and bone disease. Now the criteria have been topped up with SLIM. So now it's SLIM criteria. Apart from the 4 conventional, if we have more than 60% clonal plasma cells in the marrow, and if we have increased free light chain ratio, involved one involved more than 100, and if we have focal lesions on MRI also, then these SLIM plus CRAB, it's SLIM CRAB criteria. And to do a workup of myeloma, at baseline we need to do a routine test like CBC, blood sugar, LFT, then urea, creatinine and calcium, because hypercalcemia can be seen. Then comes the important paraproteins. We need to see the monoclonal proteins by doing SPEP or IFE, and sometimes we are doing FLC also at presentation. Then beta 2 microglobulin for staging and risk evaluation. That's why we need beta 2 microglobulin at baseline in case of myeloma, and we need a bone marrow evaluation, and most importantly we should do the FIS at bone marrow evaluation at the baseline, because this FIS plays a very significant role. It gives us the mutational profile. It tells us the cytogenetic abnormality that the myeloma is a high risk, or there are sometimes double hit and triple hit myelomas also which do very badly. And we need to do a skeletal imaging. PET-CT can also be done if a extramedullary disease is suspected. So regarding skeletal survey, the conventional thing was whole body X-rays, especially of the skull, long bones, pelvis and spine. Nowadays there are low dose whole body CT scan, then the PET-CT scan and MRI also. So low dose whole body CT scan is almost it is less exposure in terms of radiation if we do X-rays of different body parts. Although it's costly, it is very short turnaround time and it picks up the disease nicely. So if we are thinking in terms of exposure, so we are doing X-rays of different body parts, we are exposing the patient more. Regarding FIS, as I said, that FIS gives a cytogenetic workup of the myeloma. It tells us that the myeloma is a standard risk or it's a high risk. So the commonest high risk marker in Cytogenetic studies for a myeloma are 17p deletion, then the translocation 414, translocation 1416, translocation 1420, and gain of 1q. If 1q3 or more copies, then these are high risk. And in the conventional RISS classification, all 5 is not included. Then if there are any 2, then it's a double hit. If there are 3 of these chromosomal abnormalities, then it's a triple hit myeloma, which is worst in terms of treating a patient. Trisomies and hyperdiploidies are considered good in case of myeloma. Earlier we used to see DSS, Dury-Selman staging, then comes the ISS, which is still followed in some part of the country, and it is a very simple staging system to actually we can make it out only by doing beta 2 microglobulin and albumin. Stage 1, 2, 3. It was refined further with RISS. It was revised ISS. Revised ISS has the importance and it incorporates serum LDH and cytogenetic abnormalities. So as the disease evolves, we know that in revised ISS almost 60% population was in the intermediate risk stage 2. So this year 2022 it was published the R2 ISS, another revised form for ISS, which has incorporated amplification 1q, which was not there in RISS, and it has dichotomized, we can see it has dichotomized the intermediate 1 in group of the RISS into intermediate 1 and intermediate 2. It is a simple score which tells us that the mid heterogeneous group of RISS also has good and bad prognostic things. So we can employ in future the R2 ISS very soon. So after diagnosis a case of multiple myeloma and properly risk stratifying with all the available markers and tests, now we want to do how to treat the myeloma. What are the options available for treating a case of multiple myeloma? Like any other disease, first thing is what the patient wants, what the patient can tolerate. So before starting multiple myeloma, we are looking whether the patient needs therapy, whether the patient can tolerate this kind of therapy. So because the patient needs therapy, it has an active disease with all the symptoms, scab and fractures, then we will treat myeloma with these following drugs. So most commonly we have immunomodulators, then we have dexamethasone, we have proteasome inhibitors. These are the classical backbone. Nowadays we are using anti-CD38 antibody, which is Daratumumab. Then certain other investigational and new drugs are also there for multiple myeloma treatment. But basically amongst all the drugs which are there, we don't have all of them in our country, and we have to do a permutation combination with the available drugs, keeping the pocket of patient in mind. So we can see over time the treatment of multiple myeloma has evolved, and the patients are now have gone from simple melphalan and dexamethasone to Daratumumab, carfilzomib, then the transplant, which was earlier to a selected few patients, now it is part of a standard therapy upfront. And we are now, like CML, we are talking about TFR, we are talking about delaying transplant also in case of multiple myeloma. So almost 15 drugs are approved for multiple myeloma and few more are coming, and some of them are in first line, some of them are in second line, some of them are in third line. But what we need to decide that a particular drug can be for a frontline patient, but we can't use it for our patient because of the various comorbidities and especially the kidney issues. Then we need to pick and choose which one to do. Natural history of multiple myeloma is a bit tricky. It's a disease which needs constant follow-up and constant treatment, and we know that in spite of our best effort, the disease will relapse. And after the relapse, if we restart therapy with the same or different drugs, then it will have a remission phase and it will again relapse. With subsequent cycles, the disease will relapse earlier than a previous one, and the time period for remission will shorten. So if it's a transplant eligible patient as per his physical fitness and comorbidities, then we would like to talk about an early autologous stem cell transplant after bringing the patient in remission. So commonly nowadays worldwide the best therapy is VRD, which is commonly used, and if patient can afford, then it's a quadruplet. And if patient is a high risk myeloma, then straight away adding daratumumab to this VRD combination will do magic. So if patient can afford these drugs and transplant, then we are going ahead for transplant. And then depending upon the risk stratification, post transplant maintenance is either in terms of lenalidomide or in terms of a bortezomib, lenalidomide, bortezomib, dexa also some people are using. So there was a debate which one to use, which drugs, how many drugs. Nowadays it is clearly established that at least we should use 3 drug combination. A triplet is always better than a doublet in case of myeloma. And amongst the triplet, which one to use? VCD was commonly used, then VTD was there, which has shown VTD is better than VCD. Now comes the VRD. VRD is way better than VTD. VCD is still used if it's a kidney involvement disease. Then if the patient cannot afford a transplant or is ineligible for transplant, then we can give to DRD also. The Maya trial has shown DRD works better. And if it's a 3 drug versus 4 drug, the 4 drug combination is better than a 3 drug. If patient can afford, it gives a better PFS and a better OS. So there are different trials which have shown that Dara VTD is better than VTD and Dara VRD. All those multi-drug combination are very rarely used nowadays in case of myeloma. These are used upfront. If it's a plasma cell leukemia, some centers still don't like to do VTD or VRD pace. They are now happy with Dara VRD, Dara KRD. But multi-drug along with chemotherapies like Lipodox and Benda still has a role in case of myeloma, especially if it's a multi-refractory disease. So Daratumumab, as I am talking, and Daratumumab has been bring to the forefront of multiple myeloma therapy, and we are now talking about quadruplet. It's a anti-CD38 antibody. And why we are using this upfront? Because it can give us a deep and durable response. The deeper the response, we know the likelihood of patient is better, and even if patient goes for an early transplant with these MRD negative state, he is likely to do well compared to those who are not MRD negative and have not achieved a deep response. So this was a trial of Cassiopeia trial where Dara VTD was compared with VTD, and the patients were randomized in 2 different arms, with and without daratumumab. After an induction of 4 to 6 cycles, the 4 cycles were there, and then there was a transplant in all patients. Post transplant there was a consolidation again with the same therapy which was used in induction. Post 2 cycles of consolidation, patients were randomized for maintenance therapy versus observation. And the long term data of this Cassiopeia are now out, and they are showing that if we use daratumumab upfront with VTD versus no daratumumab, the outcome is significantly better. The rate of CR and MRD negativity is way better in case of Dara VTD versus a VTD. This chart also shows, but one thing to keep in mind, that in those patients who have already received daratumumab along with VTD as induction part, then Dara maintenance does not provide additional benefit in terms of MRD negativity achievement. And those who have received daratumumab upfront may skip daratumumab maintenance, but those who have not received daratumumab, adding Dara maintenance will do significantly good amount of benefit to those patients. Similar study was Dara VRD for Griffin, and the Griffin has also done 2 different phase 1 and phase 2 studies, and the design was almost similar because we were thinking in triplet versus quadruplet strategy, and it has also shown that with continuous daratumumab, the response rate over time increases. With daratumumab, the initial at the end of induction, the response rate was 12 patients were in stringent CR, CR in CR, and after the end of autologous stem cell transplant, the number has increased further. After the end of consolidation, then with further maintenance, with daratumumab ongoing, the number of stringent CR patients have increased, and patients have achieved MRD negativity. MRD negativity was judged with the multi-parameter flow cytometry. It was judged with NGS also, and with both the techniques, the response was significantly better, and it was a tremendous response if we have used Dara along with those 3 drugs. So we can see that up to initial 1.5 to 2 years, the response was, both the curves were hand in hand, but then the separation started. With continuous Daratumumab, patients remained in deep molecular response. The chances of relapse were less with continuous Daratumumab, and without Dara there were more relapses, and the progression free survival was way better in case of Dara group. So what is the role of autologous stem cell transplant? Frankly speaking, conventionally, yes, it is one of the most important therapy which a myeloma patient can get, because it gives you high dose melphalan, which is very important for multiple myeloma. So it improves overall survival by almost 1 year in cases of multiple myeloma who can afford, and we should counsel a patient presently in this era, those who can afford, yes, you go for transplant upfront. But there are now, with the upcoming progress and advantages of some other therapies, our thought may change. This was the landmark study in NEGM, which has shown that doing a transplant gives you a PFS advantage at least by 1 year. This is an LCIN trial which was used for Dara VMP versus VMP in those cases who are frail, who are not fit for upfront transplantation, and we have seen that Dara VMP is markedly better. And Maya trial was also done. It gives Dara Lendex, which is a 3-drug combination in elderly frail patients who are unfit for multiple myeloma. We'll skip this one. Then the maintenance therapy in myeloma. Maintenance therapy in myeloma is used irrespective of transplant or no transplant. If you have achieved maximum possible response either by treatment induction or by incorporating a transplant, you switch the patient to maintenance therapy. You don't want to give them whole list of drug lifelong. So post transplant, ideally now the maintenance therapy is lifelong till the patient can tolerate that particular drug, and we are commonly using lenalidomide or bortezomib post transplant depending upon the initial risk status. If the patient is standard risk, we are using lenalidomide. If the patient is high risk, we are using bortezomib, nowadays bortezomib with dexamethasone. And we can see that virtually all patients of multiple myeloma will relapse, and with each relapse the time of their remission will shorten. So when should we start treatment for multiple myeloma at relapse? Like all other diseases, we have 2 different things, whether we need to treat or we can watch and wait. If it's a symptomatic disease, symptomatic relapse, definitely we need to treat. If it's an asymptomatic and biochemical relapse, then we can have a stringent eye and we can have a watch and wait policy for that symptomatic biochemical relapse. This is the most important thing, what to choose from, because we already have used certain drugs which are still available to us, and we have certain new drugs which are approved for subsequent therapy. So it's a trap, and we need to see the timing of relapse. We need to see what was the response to prior therapy, then the aggressiveness of relapse, and the performance status of patient at the time of relapse, and depending upon these we are choosing different drugs. And these are some of the important drugs which are available, but this chart has made our life very simple. If it's a lenalidomide sensitive disease, we need to use a len based regimen again. If it's a len refractory disease, then we are treating it in a different way. Most of the time our patients are len sensitive, then we incorporate lenalidomide dexa along with a daratumumab or carfilzomib. We need to up the drug from what was there earlier. So if it was like daratumumab and carfilzomib was not used earlier, we should incorporate those drugs at the time of relapse. And if the patient is len refractory, then we are using different class of drugs, but we should try to use at least a triplet, some of the drugs which were not used earlier. And to keep this in mind, if a patient is len refractory, he is likely to be pomalidomide refractory also, same class of drugs. So of those 15 drugs what are available to us, we have thalidomide, lenalidomide, bortezomib, endoxifen, then we have carfilzomib, pomalidomide, dara, and penabinostat. And most high-end drugs are not available to us in our country. Some are available but are costly. So, and we need to see that there are certain drugs which have significant side effects also. So proteasome inhibitors like bortezomib, when we are using, there is a risk of herpes reactivation. So we should keep the patient on acyclovir prophylaxis. Immunomodulatory drugs also have their chunk of disadvantages, like they can lead to more infections. Then we have monoclonal antibodies and steroids. Steroid, we all know what are the basic problems with steroids. So different drugs, they will treat myeloma, but they can create some other problems to the patient. So we need to juggle around nicely. And regarding supportive care of multiple myeloma, because it involves bone frequently, the bone disease should be looked after. If there is a lytic lesion, then we can use denosumab. If there is no lytic lesion, then denosumab is not recommended, and the gold standard we are still using is bisphosphonates we are using. We can go for a palliative radiotherapy if there is significant pain or an impending fracture, and for renal failure we are using high-dose dexamethasone, cyclophosphamide, and concentrated regime also for 14811. And for hematotoxicity, supportive care. Then infection I would like to mention, very important, that now the guidelines are saying, and after the team trial, that for first 3 months of multiple myeloma, irrespective of risk status, you should keep those patients on prophylactic antibiotic. At least add a levoflox or a azithromycin for first 3 months of multiple myeloma treatment, whatever is the risk category. Because those patients' plasma cells are defective, they don't have enough good amount of immunoglobulins, and they are very susceptible for especially pneumonia. Do vaccinate all your patients of multiple myeloma at baseline with pneumococcal and influenza vaccine. Put them on levoflox or azithromycin and other supportive care. These are other different novel agents, and we can see that the future of myeloma is very bright. It's emerging with new therapies. What are these new therapies? These are B cell maturing antigen targeted therapies. So we say them BCMA targeted therapies. There are different antibody drug conjugates. Then there are BiTEs which are available. There are CAR T cell therapy, which is most high end therapy, which is spoken in cases of hemat malignancies nowadays. CAR T cells are not new for myeloma. Different trials are going on for CAR T cells, and especially because we have a targetable antigens, it's a BCMA, we can go for CAR T cell therapy, and CAR T has been approved for myeloma also after 4 previous line of therapy. These are different CAR T cells, sitalecleucel, edilecleucel, orvacel, and they all have shown that the overall response is around 50 to 80% in different trials, and these are the patients which are heavily pretreated, significantly refractory to almost all different lines of treatment. So if those patients are showing 50%, 80% overall response, it's a thing to joy. Belantamab was approved recently. There is a huge amount of conflict and doubt whether this drug should be used or not. And in this era of choice, I call it a era of choice, because now we have different options, and patients also have different options because of betterment of diagnostic facility, better supportive care. So what we should do, we are using a triplet versus a quadruplet. I choose quadruplet if patient can afford. If triplet, we are using VRD or VCD. If the patient relapses, then if len sensitive, I am again using lenalidomide based drug. So with this, now this should be our tech clinic or hospital message, that treatment depends on comorbidities, the frailties, the possibility of doing a transplant, and all these things should decide which way we want to go. ASCT presently should be considered in all cases of myeloma and should be discussed, and should definitely be done after a first relapse. It should not be deferred beyond that. And there is no easy algorithm for managing a refractory myeloma. It is a very difficult disease to treat, especially considering the age and comorbidities and kidney disease along with this. Patient specific issues should be the core for deciding therapy, it should be pocket friendly, it should be patient friendly. Proteasome inhibitors, IMiDs and HDAC inhibitors like panabinostat have improved the course of relapsed myeloma also, and there are novel therapies, so there is still a lot more to achieve and lot more to go for multiple myeloma. Thank you. Any questions?
Yeah, first of all, congratulate to you that you have done very elaborative presentation on multiple myeloma, because to cover in one talk, it's really very difficult. Secondly, I want to ask one question regarding that. Do you have some experience on Tele versus Lina head-to-head, or what is now in practice where you are practicing in Jaipur? Which one you prefer among these two?
Amongst which one, lenalidomide versus?
Thalidomide.
Sir, I had used both frequently in my previous institute. At Tata, we were fond of thalidomide and cyclo also, the Vellore thing. Nowadays, for last 4.5 years, I am using lenalidomide in all patients. If there is significant kidney issue, then I am not using lenalidomide. Otherwise, lenalidomide is a very good drug and most patients tolerate. But we won't go as high as the Western world. Our patients doesn't reach the 25 mg benchmark mostly. So I start from lower dose 15 mg, then 20, then 25, depending upon tolerability. But I would vote for lenalidomide over thalidomide.
After bone marrow transplant, longevity, how long it patient can survive?
So the bone marrow still post BMT patients will relapse, but the chances of staying in remission is almost 1 to 1.5 year more, and almost 35% stays in remission post transplant. So it's patient should be counseled that even if you are undergoing a BMT, your chances of relapse are still there. It looms around. It is not that myeloma will not relapse after transplant. Now with post transplant maintenance, the things have changed. Post transplant maintenance is keeping that disease still in check, but they invariably they will relapse post transplant also.
So choice is still transplant.
So for us in India, the choice is still transplant. But if we talk about the developed countries or those who are rich can afford anything, now then it's a catch-22 situation, sir.
So with your permission, we'll move on to the panel discussion.
Yes.
So it gives me great pleasure to introduce as panelists Dr. Manoj Mahajan, medical oncologist from Udaipur, Dr. Ashish Verma, clinical hematologist from Jaipur, Dr. Vishnu Sharma, clinical hematologist from Jaipur, and Dr. Ankur Punya, medical oncologist from Jaipur. Over to you, sir.
So it's myeloma R and we are discussing myeloma, and as sir asked, the choice is still transplant. This talk will give some light on whether the choice is still transplant or when to do, how to do. This is the thing. So this is impact of time to transplant on outcome with addition of novel agent. There are certain drugs which are available nowadays, like especially the Daratumumab. Daratumumab has moved the field of myeloma. It can be rituximab to NHL. So basically for a new multiple myeloma treatment, we decide whether the patient can go for an autologous transplant or not. If it's a transplant eligible patient, we decide on therapy. If it's a non-eligible patient, we choose otherwise. So I would like to ask first Vishnu sir. Sir, how do you decide about whether the patient is fit for transplant or not? Yes.
See, age is the most important thing for to decide the performance status of the patient. So usually in India, patients more than 65 are usually not fit for transplant. So age, comorbidities like patient is having diabetes, advanced renal failure is relative contraindication for transplant. So we can transplant even in patients with renal failure also. So age, comorbidities, infection, and like if patient is affordable for novel agents and at the verge of around 60-65 years, so we can go away with transplant by using these novel agents.
Yes, yes. Rightly said, age is most important, and the associated comorbidities which myeloma brings itself, and age-related comorbidities. These should be looked in, and if patient is, you think it's a risky case, avoid transplant. So, like 65 is the cutoff.
Just a comment. Age is not like it's not the final in terms of biological age. If patient is physically fit without any comorbidities, and even in 60s, 70s, in such situation, the transplant can be considered.
Yes. So, like this slide mentions whether the patient has with this particular age comorbidities or not. So you need to decide whether patient can tolerate this intensive therapy. Only this much. So, Dr. Ankur, next question. What is your approach to a newly diagnosed myeloma? Suppose he is a fit and unfit, both cases.
So for a fit patient, I would prefer to give the induction therapy. That now depends on the high risk or a standard risk. High risk as now recommended by Mayo as well to give a quadruplet if possible. Otherwise, triplet is the standard for most of the patient will receive eventually a triplet only in the first line. In a fit patient, ideally they should go for transplant, irrespective of the response, whatever response we get. Ideally, all the patients should go for transplant because eventually most of the patient won't be able to take, the second line, third line treatment is not possible for most of our patients. So we'll try to give the best possible upfront. For the patient who are not fit for transplant, yes, then we'll go for induction for a 6 to 9 months period and then followed by what therapy for the maintenance.
Yes, rightly said. If patient is eligible or non-eligible for transplant, that decides his or her initial treatment. It is usually an induction followed by an high dose chemotherapy with an autologous stem cell rescue. So, going further with this debate, there was this determination trial which was published recently in NEGM and have been presented at ASCO also. This is a thing which is for debate and it is applicable more to the Western world. Nowadays they are saying yes, if you do a transplant, it definitely improves your progression-free survival, but absolutely no change on the overall survival. We can see the upper curve, the PFF is way better, chances of remission is better in case of those who underwent a transplant, but the overall survival there was no difference because nowadays there are different new drugs which are available, you can use them post-transplant also. Considering our situation, if a patient of a particular malignancy at very beginning when the cancer was diagnosed, there is a big huge stigma in the family and society and financial burden, and if that patient relapses after say 2 year, 3 year, 4 year, then that family's energy and finances to remobilize for treatment, to redo the treatment, it's a big headache. So if we can keep our patient in more and more progression free state, it's good, I think, because family doesn't need to think twice in that case. But this trial have clearly shown that if you do a transplant, if you don't do a transplant, overall survival does not change. Now it's up to the patient, it's up to his insurance and finances and from where he comes. If he can manage some of the drugs later on, he can avoid transplant. So this is nowadays a golden boy of multiple myeloma treatment. As I said, it can be almost parallel to rituximab, but because of its prohibitive cost, we are unable to use it upfront in all the patients. So Daratumumab is an anti-CD38 antibody and it has different actions. It kills myeloma cells, it increases the apoptosis by complement-dependent toxicity, then antibody-dependent cell killing, phagocytosis, and it modulates the immune system also. It increases the cytotoxic T cells, and it has been approved as a monotherapy. It has been approved as combination therapy in upfront case of newly diagnosed multiple myeloma, both eligible and not eligible for bone marrow transplant. And because we are discussing timing of transplant in novel agent therapy, so we are discussing about these different trials. They are different, like Lyra, Griffin, Elsan, Maya, Cassiopeia. These all are DARA-based trial, and they have used doublet versus triplet, triplet versus quadruplet. What is the response and how things are going on? It's more of a research kind of thing, and these trials have shown that yes, this antibody works and it can be used, but the timing of transplant is still debatable, like will come next. So this was a Lyra study which has used Daratumumab along with VCD and without VCD. So they have shown that Dara VCD is a good choice, and if you use Dara maintenance post transplant for 1 year, then the chances of remaining in stringent CR is way better without maintenance. I will skip. I will come to some of the next slide which are important. So my next question is to Dr. Ashish, that if you planned a patient for Daratumumab, and especially if it is upfront therapy, how do you counsel the relative regarding its cost and use, how long it will be, and how many of your patients have been convinced and are taking this drug?
See, if we see multiple myeloma, so actually this is not a curable disease. This disease will relapse, and each relapse disease become more refractory, and the remission will be shorter. So I will counsel the patient, if we hit hard and target to attain a VGPR or CR, so it is better to prolong the remission and consolidate with the autologous transplant. So if we do a quadruple therapy including DARA, if patient is create normal including VRD, so this is the best regime we can achieve a CR, even MRD negativity, and consolidate further with the transplant. So if finance is not the issue, so I will start a quadruple therapy. A patient is eligible for transplant and consolidate with the transplant. And if patient is 17p deletion, if high risk cytogenetics,
Yes.
I will counsel even for tandem transplant. It is better. So yeah, if finance is not an issue, I will quadruple, and it is better. If we hit harder upfront, because every relapse disease become refractory, remission is shorter. So most probably this one my approach.
These are the magic word which I learned initially in my training: hit hard and hit fast. Use your best agent upfront. Don't wait for them to be used later on when the patient relapses. Only exception if he is not physically or financially fit. This was the study which we have discussed earlier also, the Griffin, which has used DARA VRD versus a VRD thing. So my next question is to Manoj sir. You are the senior most and most experienced amongst us. So if your patient has achieved stringent CR and say MRD negativity with DARA VRD, would you still insist him to go for transplant, or you leave it to the patient? Yes, okay, you decide.
No, if patient is transplant eligible, we should emphasize, we cannot do away, as per the current evidence, we cannot do away with the transplants. Though DARA has improved the deeper response rates to the great extent, but transplant is still in the picture. So if patient is in CR and MRD negative and post transplant, probably he has better chances of having prolonged remission free survival, or DFS we can say.
Yes. Rightly said. If the patient undergoes these all drugs, most important the transplant, in his early part of therapy, then his chances of staying in remission is more, and that is topped up with Daratumumab. So the transplant is a backbone for all cases of multiple myeloma.
Patient, we should emphasize this more.
Yes.
Elderly, one of my patients is almost 6 years now.
Yes, it's
Post-transplant.
completely agree, sir. Here we can see that the arm without Dara has done inferior, and the arm with Daratumumab has significant better all parameters in terms of MRD negativity, in terms of CR, in terms of NGS MRDVT. So durable MRD negativity has lasted till almost 2 years if we are using Daratumumab post maintenance versus no Daratumumab. And we can see that at 6 months, at 1 year, it is significantly better. But there is not much of an overall survival benefit in terms of using this or not using this. Some of the common adverse effects are like it's most commonly the hematotoxicity. Patient presents with neutropenia, then thrombocytopenia, and sometimes patients have upper respiratory tract infections, which is very commonly seen with Daratumumab. We should use some antibiotics. Then there are infusional toxicities. And this was the Cassiopeia, which has Dara VTD versus VTD. It is almost similar to the Griffin. It has also shown that yes, you take those patients, you do transplant, then post-transplant you use this drug for long, and it is going to give you better benefit. It's an SIP kind of investment. You do a regular investment, you get a good outcome. Response rate are better with Dara VTD compared to VTD. We can see the stringent CR is increasing post consolidation in cases where we use this antibody. So next question is to Vishnu sir. Sir, regarding your Daratumumab patients, how commonly you see adverse event which is Dara related? Suppose a patient can afford, but means are you concerned that this patient cannot tolerate, he will have some kind of adverse event and I can withhold?
See, infusion reactions are very common, especially at first injection. So patient should be started with pre-medication. And after that, infusion reactions are uncommon. So Dara is quite tolerable drug with very few easily manageable side effects. And one thing I would like to add, the RBC extended phenotyping should be done because it interferes with the blood booking and cross matching.
Yes.
So every patient should have RBC extended phenotyping before starting Daratumumab. But side effects are easily manageable, except first Dara infusion should be given in hospital setting. After that, we can give like in daycare setting also.
Very important point, infusional toxicity and RBC cross matching. Anti-CD38 antibodies, just 2 minutes. Anti-CD38 antibodies, CD38 present on red cells also. So in that Cassiopeia trial, it was found ultimately that VTD therapy has resulted in a better clinical benefit. It was significantly statistically better. IFM trial is also there. I'll skip this one with time constraint. The most important take home for me from this is that ASCT is an important event in patient's treatment line, and now it is up to patient and the treating physician to decide when to place this ASCT for that particular case, whether it should be upfront, whether we can delay it. With determination trial, we have seen that ASCT doesn't prolong overall survival. Considering our scenario in India, where all top-end drugs and costly drugs are not easily available to patients, we are still keeping autologous transplant earlier for patients' treatment. And it most important, the timing of transplant, because there are certain life events in cases of patients. A patient is elderly, उसकी बेटी की शादी होने वाली है, उसके रिटायरमेंट होने वाला है, and there are some time when patient can't be caged for 6 months, 7 months peri-transplant for that particular time. And this is important to choose that we can defer or we can delay the transplant in those particular limited scenarios.
Sir, one small question.
Yes, sir.
Any advantage of adding anabolic androgen as an adjuvant to these disorders?
No, sir. To me, I don't see any advantage of anabolic androgen, sir.
Tetradobolin like that?
No, sir.
No advantage in myeloma also, in
No, sir,
CML
to me.
also.
I have one doubt. Rather, I will ask with the company person. Any update on subcutaneous DARA? Is in
Yes,
It's available but not in India.
there was a trial I have skipped and not in India.
yeah, but trial are there that we can skip the infusional reactions.
It's not in India.
Not in
Perseus trial is there with
Yeah.
subcut Dara VRD versus VRD. I have skipped that because we already don't have some of the drugs.
Just one question from my side. If our seniors can also take this. The literature mentions that IgG and lambda subtype of if that restricted myeloma is there, then daratumumab has similar antibody. And when we do a repeat immunofixation for the response assessment, sometimes that antibody can interfere in the assay. So how do we conclude that it is assay related or it is a progression, true progression? So they mention literature mentions DIRA assay. Probably that is not available in India. But how do we assess or anybody has faced such problem?
Yes, sir, Dara is anti-IgG1 kappa.
Yeah.
So in cases of myeloma which are kappa and G, this is going to be a headache for us because we
How do we
can't.
differentiate?
We are
DIRA
unable-
assay is mentioned,
Yes, sir.
but it is not available in India. So how do we assess in our patient if this scenario comes? So is there any an Indian jugaad solution?
No, sir.
Because it
We
is not available.
if we are seeing the
Clinically we can just, but how do we document it? Medically you cannot continue with the DIRA if you don't have a.
so IFE will be a problem, but FLC is okay, sir, because it's a complete antibody, not the.
Can we document it
Yes, sir.
and continue the DIRA?
Yes, yes, sir.
But on what background?
So free light chains Dara is a antibody with IgG kappa that can be a problem with immunofixation, and we sometimes face it.
No, I know that. That is what I am saying. How to safeguard ourselves legally? How will you prove it?
Maybe some bone marrow might be the way to do everything. Maybe 6 monthly we can do a bone marrow just to document. Might be more better reliable, predictor of whether patient. Yes.
Yes. Thank you. Clonosec will come and help us. Thank you.
Thank you so much, sir. Thank you to all our panelists.